মাঝে মাঝে দেখা যাবে।
নুসুর ম্যাডাম, আরেক মিনিট পর আমরা শুরু করব।
হ্যাঁ হ্যাঁ, তোমরা শুরু করো।
নুসুর ঠিক 9টায় শুরু করো।
জি আপু।
শানা যদি ম্যাডাম জয়েন করেন।
মুসাররাত ম্যাডাম এসেছেন?
53। হ্যাঁ, সুমিরটা একটু কনফার্ম করো, কারণ শুরু তো সুমির। সুমিরটা
না,
একটু
আমি সুমি
কনফার্ম
আপাকে
করে
ফোন করছি,
তারপরে।
ফোন ধরছিল না। আমি আবার ফোন করছি।
ম্যাডাম আসসালামু আলাইকুম।
আসসালামু আলাইকুম ম্যাডাম।
ওয়ালাইকুম আসসালাম ম্যাডাম, আসসালামু আলাইকুম।
আসসালামু আলাইকুম
হ্যাঁ,
ম্যাডাম।
ঘুমাইও না। ক্লাস শুনছো আর ঘুমাইছো, আমি কিন্তু দেখছি যে
কবে
শাহি
ম্যাডাম?
ঘুমায় আমার ক্লাসে
আপনার ক্লাসে ম্যাডাম আমি প্রত্যেকটা
দেখে।
স্লাইডও বলতে পারবো। আমি ছবি তুলছি কতগুলা, এক সেকেন্ড আমি ঘুমাই নাই। ছবি তুলছি তো ম্যাডাম।
আচ্ছা, আমার
ছবি
কাছে মনে হয়েছে সেই
কোমর ফাঁস করে দিলাম। একদম আমি বসেছিলাম, এক সেকেন্ডের জন্য নড়ি নাই। রুনা
ম্যাডাম
পাটা
এর ক্লাসে ঘুমাইবার কোনো উপায় নাই, এত ইনফরমেটিভ।
সেই চাই প্রশ্নে উঠে না।
না, আমি ভাবছিলাম যে ওটা টায়ার্ড বেশি,
একটু
সেটার
না
জন্য
ম্যাডাম, আমি
শি
রুনা
ওয়াজ
পাটার কথা
স্লিপিং।
শুনছি, এসে
যাই
মনে
হোক, অসুবিধা নাই।
ডিসকাসও করছি। রুনা পা শেষে পরে অনেকক্ষণ কথা বলছি আমরা।
আচ্ছা
থ্যাংক ইউ ম্যাডাম।
আচ্ছা, আমরা এখন 9টা বাজে, লাইভে চলে যাবে কিনা দেখো। 67 পার্টিসিপেন্ট জয়েন করছে। শাহাদাত কোথায়? শাহাদাত
জি ম্যাডাম আছি।
কথাই বলেন। আছো তাহলে, 9টা বাজে, কথা ছিল 9টায়। দেখো সুমি ম্যাডাম জয়েন করছেন কিনা। সুমি জয়েন করলে শুরু করে দাও।
জি
সুমি
ম্যাডাম,
জয়েন না করলে তো শুরু করা যাবে
সুমি
না।
জয়েন করছে না, সুমি এক্ষুনি জয়েন করছে ম্যাডাম।
ম্যাডাম আমরা লাইভে আছি।
আচ্ছা, সুমি জয়েন করলে শুরু করো, তার আগে না নুসুর।
ম্যাডাম
জি
আসসালামু
ম্যাডাম, জি।
আলাইকুম।
হ্যাঁ, সুমি আপা জয়েন করে নেই এখনোই। একটু ওয়েট করো, তাইলে আমি ফোনে জয়েন
ও
করছেন উনি।
ফোন করেছে
জি আপু।
সাথী, ও বলছে আমি এক্ষুনি জয়েন করছি।
শুরু করে দিবে ম্যাডাম তাহলে।
হ্যাঁ,
আসসালামু
তার
কারণ
আলাইকুম।
এক মিনিট পরে কিন্তু আপা তো, আমার মনে হয় আপা একটু
ম্যাডাম
আমরা
জয়েন করুক,
হ্যাঁ।
সুমি ম্যাডাম জয়েন করুক।
হ্যাঁ, দুই এক ওয়েট করাই যায়, আমরা ওয়েট করি। আর তাজবির সাহেব কি জয়েন করছেন কিনা
না, এখন
আমি
উনি করেন।
তাজবি
দেখি
স্যারকে
না ওনার
ফোন
ফেস।
করে
না, করছো, বারবার ফোন করার দরকার নাই, জাস্ট মেসেজ দাও, তাইলেই হবে। এত বারবার মানুষ
জি,
ফোনে ডিস্টার্ব করার দরকার নাই।
ওনার তো একটু পরে বোধ হয়, সেই জন্য হয়তো বা
এখন তো করার কথা। জি ম্যাডাম।
তুমি আসছে, আমাদের 100 পার্টিসিপেন্টস হয়ে গেছে।
ভেরি গুড। সাথী আবার ফোন দাও তাহলে সুমিকে।
তোমার কাছে ফোন নম্বর নাই, তুমি সাথীরে বলতেছো কেন?
আমি করেছি ম্যাডাম, আমি করেছি, বলেছে আমি এক্ষুনি ঢুকছি, কিন্তু এক্ষুনি ঢুকছে তো এখন তো ঢুকে নেই, এই জন্য
হ্যাঁ, ঠিক
বললাম।
আছে, বারবার ইয়ে করে লাভ নাই, ও তো চেম্বার করে রাতে।
জি জি, ও
ও
বলেছে আমি
মনে
এক্ষুনি।
হয় বাসায় ঢুকে তারপরে জয়েন করবে, সেটার জন্য জয়েন করছে না।
আচ্ছা আচ্ছা আচ্ছা।
কালকে যখন আমাদের কি একটা মিটিং ছিল দেখো না, সেইখানে সে ওই রাস্তার থেকেই কথা বলা শুরু করছে। আহ, কালকে রাতের একটা এমার্জেন্সি ইসি দিছিলাম না।
অনেক 109 জন হয়ে গেছে, মাশাল্লাহ।
হ্যাঁ, উই শুড বি হ্যাপি, উই শুড বি হ্যাপি, কিন্তু এই স্টাইল চালানো যাবে না। সামনের মাসে বাইর হওয়া লাগবে। নাকি কেমনে সামনের মাসে বাইর হইতে পারবো না?
এই সুমি ঢুকেছে
রোজা।
ম্যাডাম, সুমি
আচ্ছা,
ঢুকেছে।
সময়
আসসালামু আলাইকুম ম্যাডাম।
ম্যাডাম
আচ্ছা,
আসসালামু
ওয়ালাইকুম
আলাইকুম।
আসসালাম। তোমাকে সম্মান করে আমরা এখনো শুরু করি নাই, তুমি যেহেতু আসছো এখন আমরা শুরু করব।
আচ্ছা ম্যাডাম।
এটা হলো তোমার কষ্টের প্রাপ্য, যে সব সময় কষ্ট করো, কাজে সম্মান আমরা করি।
আসসালামু আলাইকুম।
থ্যাংক ইউ ম্যাডাম, থ্যাংক ইউ।
আচ্ছা, তা আমার মনে হয় নুসুর শুরু করে দাও। নুসুর শুরু
জি
করবা? করো
জি ম্যাডাম।
করো।
Assalamu alaikum. Good evening. I'm Dr. Nushur Akhtar. Welcome you all to OGSP monthly online scientific seminar. Respected audience, today our context is a very time-demanding challenges context, that is maternal collapse, which is a real challenge in our obstetric care. We all know maternal collapse, a life-threatening acute event during pregnancy or within 6 weeks postpartum. Learned audience, today our chairperson of this session is respected Professor Dr. Firoza Begum Madam. Professor Firoza Begum Madam, President, Obstetrical and Gynecological Society of Bangladesh, President, Maternal Fetal Medicine Society of Bangladesh, Vice President, Bangladesh Society of Medical Genetics, Vice President, Fertility Sterility Society of Bangladesh, ex-editor, Bangladesh Journal of Obstetrics and Gynecology, Council Member, SAFOG, Council Member, AFOG, Member, MFF Subcommittee of AFOG, Member, European Society of Human Reproduction and Embryology, Member, Society of Maternal Fetal Medicine, and pioneer in the starting high-risk pregnancy services in Bangladesh, recipient of the Young Gynecologist Award by AFOG in 1993. She is the author of textbook High-Risk Pregnancy for Postgraduates. Today, our keynote speaker is Professor Tabassum Parveen, Chairman, Department of Fetal-Maternal Medicine, Bangladesh Medical University, Vice President, Maternal Fetal Medical Medicine Society, Bangladesh, Secretary General, Bangladesh Perinatal Society, and Life Member, OGSP. Our respected panelist, a panel of experts, Professor Dr. Sheikh Jinnatara Nasrin, Gold Medalist, Professor OBGYN in Shikdar Women Medical College, Chairman, CME Committee of OGSB, Organizing Secretary, Bangladesh Perinatal Society, Secretary General, Bangladesh Menopause Society, Secretary General, PCO Society of Bangladesh, Member Secretary of the CPD Committee of BCPS, Scientific Secretary of Gestosis Chapter, Bangladesh, writer of a book, Management of Menopause and Chapters of National and International Books. She had also more than 50 publications, and she attended national and international conferences as invited speaker. Our another panel of experts, Professor Shahnara Choudhury, advisor and professor at Marine City Medical College, ex-professor and former head OBGYN Chittagong Medical College, former president OGSB Chittagong branch, organizing secretary outside Dhaka Fertility Society Bangladesh, vice president Eurogyne Society Bangladesh, former chairperson Medical Education Committee, former research in chief journal of Chittagong Medical Teachers Association, ex-chairperson Research and Ethical Committee, life member EASP and PCOB, writer of the book Proshuti O Proshob, and many publications both national and international journal. Another respected panelist, Professor Fahmida Islam Choudhury, head of the department OBGYN Chittagong Medical College, General Secretary OGSB Chittagong branch. Our another panel of experts, Dr. Tazbirul Islam, Clinical Associate Professor, Rosalind Franklin University of Medicine, Indian University School of Medicine, and he is consultant in the Department of Pulmonary and Critical Care Medicine, Northwestern Medicine, McHenry, USA, founding chairman, Planetary Health Academia. Our another respected panelist, Dr. Masuda Sultana, Assistant Professor, Fetal-Maternal Medicine, Dhaka Medical College, life member OGSB, member Maternal Fetal Medicine Society of Bangladesh. Now first, I humbly request our Professor Musarat Sultana ma'am to give welcome address. She is the Vice Principal and Head of the Department OBGYN Dhaka Medical College, Member Secretary OGSB, FIGO Young Gynecologist Award winner, Treasurer Female Pelvic Medicine and Reconstruction Bangladesh, South Asian Regional Representative of ISOPS. So I humbly request Professor Musarat Sultana madam to give welcome address.
Respected President of OGSB, and respected colleagues, today's colleagues and seniors, and dear participants. Assalamu alaikum and a very good evening to you all. It is my pleasure and privilege to address you in this monthly seminar, which is after a long time I have started this seminar online after visiting our branches in various districts in previous months. And today's discussion is a very time-demanding topic. It is on the maternal collapse challenge in obstetric care, and focusing on a critical and often life-threatening issues in maternal collapse in obstetric care. Maternal collapse, though relatively uncommon, it remains one of the most challenging emergencies we face. It is sudden, unpredictable, and demands immediate coordinated action of various disciplines. The causes may range from obstetric hemorrhage and eclampsia and amniotic fluid embolism, sepsis, and even cardiac events. Each case tests not only our clinical knowledge, but also our preparedness, teamwork, and system efficiency. In Bangladesh, the challenge is even greater. Delays in recognition, limited resources, and gap in multidisciplinary response can significantly affect the outcome of the mothers. Therefore, our focus must be beyond individual management. We must strengthen our protocols, ensure regular drills, and promote the effective communication among the obstetricians, anesthesiologists, nurses, and critical care team. This seminar is an opportunity for us to reflect, learn, and share our experiences with our members and the expertise. And let us commit to build a system where no mother is lost due to preventable causes. Preparedness, vigilance, and teamwork must remain at the heart of our practice. So let us all work together to save these mothers who are going to be missed very quickly. So I welcome you today in today's session. I think you all will enjoy the session, and we can learn the things from our respected panelists, and also we can apply these things in our day-to-day practices. And I welcome again the participants and also our members in this session today. I welcome you and enjoy the session. Thank you all.
Thank you, Madam. Now I request Professor Tabassum Parveen, Madam, to give her valuable speech regarding our today's context, maternal collapse, challenges in obstetric care. Professor Tabassum Parveen, Madam.
আমার স্ক্রিন দেখা যাচ্ছে? Am I audible as well?
তোমার স্ক্রিন
জি
দেখতে
জি
পাচ্ছি
ম্যাডাম।
and audible.
Okay, thank you, madam. So, Honorable Chairperson, respected panelists, dear moderator, rapporteur, and dear audience, Assalamu alaikum. Welcoming you all on my topic of presentation on maternal collapse, challenge in obstetric care. I have no conflict of interest to declare. The contents of my presentation is understanding maternal collapse, its causes, its early warning sign, impact of physiological changes of pregnancy on resuscitation and resuscitation procedures. Dear audience, let's begin with the story. It's 3 a.m. You are just exhausted, planning to take rest after a hectic duty. Suddenly, an emergency call. A pregnant woman is brought in emergency room. You assess her quickly, and in the moment you realize she is in the state of collapse. Now what are you going to do? So let's try to get the answer from my presentation on maternal collapse, a condition when every second defines 2 lives. Maternal collapse is defined as an acute event involving the cardiorespiratory system and or brain, resulting in a reduced or absent conscious level and potentially death at any stage in pregnancy up to 6 weeks postpartum. So, what is an acute event? It is a sudden, severe, and unexpected health issue that requires immediate medical attention. And this statement about acute event is quite adequate to understand what is maternal collapse and what we have to do. Now, I would like to clarify 2 points, that is whether cardiac arrest is synonymous with maternal collapse. No, it is not. Cardiac arrest is a life-threatening emergency, more severe than maternal collapse, where heart suddenly stops beating. So, there is cessation of the blood flow to the vital organs. On the other side, if not promptly treated, maternal collapse may progress to cardiac arrest. Another is maternal near miss. Yes, it is strongly correlated with maternal collapse. Maternal collapse and maternal near miss, or MNM, has got common link, the 3 delays model, that is delay in seeking care, delay in reaching facilities, and delay in receiving appropriate care. Actually, the maternal collapse lies in between MNM and maternal death. Now, maternal collapse is really a challenge for the obstetrician because it is sudden and unpredictable. Minutes determine survival here, and obstetrician has to take the dual patient responsibility. Both mother and fetus need simultaneous rapid decision. Regarding the incidence, as morbidity data are not routinely collected and reported in national statistics, so the true incidence is difficult to estimate in our circumstances as well as in the Western world. However, if we look at the data on the maternal mortalities in Bangladesh, it indicates its high prevalence, at least in our setup. Now, the causes of the maternal collapse, obstetric causes are hemorrhage, eclampsia, sepsis, amniotic fluid embolism, uterine rupture. However, it is not always obstetric causes. There are non-obstetric causes, and major causes, non-obstetric causes are cardiac disease, pulmonary embolism, anaphylaxis, trauma, drug toxicity. But the most common one is vasovagal attack and epileptic seizures. Now, this slide is very important because it is actually showing the reversible causes. Actually, the reversible mechanism through which collapses passes, and these conditions are reversible where we have to act to reverse the collapse. So this is very important. And the Resuscitation Council of UK, for easy memory, named it as 4Hs and 4Ts. 4Hs include hypovolemia, hypoxia, hypo and hyperkalemia, and hyponatremia and hypothermia. And 4Ts includes thromboembolism, tension pneumothorax, cardiac tamponade, and toxin. So maternal collapse is a critical point, but we have to keep in mind that it is frequently reversible and it is the last opportunity to save lives. If we look again our mortality data, hemorrhage, eclampsia, and abortion is responsible for 62% of the maternal death, all of which are reversible if we work on time. Like hemorrhage leads to hypovolemic shock and collapse, but we can reverse the hypovolemic shock by quick control of the bleeding and fluids or blood. On the other side, eclampsia leads to seizures, then collapse. We have to work strongly against seizures so we can prevent it. Another one is sepsis. Unsafe abortion leads to it. And whenever there is sepsis, there will be collapse if we don't treat it. So we need to treat it immediately. So in cases of maternal collapse, we have to keep in mind that death is not sudden. There is a window to act where we have to work. So whenever there is collapse, we have to think 4HS and 4TS, identify the background cause, treat the cause immediately so we can reverse the condition and save the life of the mother. Now, the brief presentation or description of the causes of maternal collapse. Number one is hemorrhage, and PPH is the most common one. Other causes are placenta previa, parkrita, placental abruption. About parkrita, particularly during surgery, ruptured ectopic, ruptured uterus. But this hemorrhage becomes really a challenging one when there is occult bleeding, where we need high degree of clinical precision. On the other side, if we can go for ultrasonogram, we can detect concealed blood within the abdomen. Another challenge with hemorrhage dealing is that its signs appear late. Tachycardia, tachypnea, and hypotension are the late evidences when there is more than 25% of the blood loss, or which amounts to about 1.5 liter. So we have to work in that way, considering this fact. And management, we all know, that is control of bleeding, remove the source, and rapid blood replacement. Eclampsia is a preventable condition, but is still a major cause of maternal collapse and mortality in Bangladesh. Why? Because the patient as well as the caregiver misses the warning sign. Warning sign like severe headaches, difficult breathing, nausea, vomiting, abdominal pain, blurred vision, anasarca. Because we do have a very magic drug in our hand, Maxalf. If we find these things in a case of severe preeclampsia, we can utilize it as a preventive measures. And for seizures, we know that Maxalf, there is no drug like Maxalf. Now, maternal sepsis is another major yet largely preventable cause in Bangladesh. Not only this, it is actually a reflection of substandard care. Because it is common after unsafe abortion, prolonged neglected labor, and so on. And the challenge with maternal sepsis is that it progresses to shock rapidly and leads to multi-organ dysfunction. We can send major lactate and send blood for culture sensitivity, but we have to start a broad spectrum IV antibiotics within our 1 hour of recognition, which is very important. Another challenge is hypotension in maternal sepsis. If there is hypotension and or serum lactate more than 4 millimole per liter, we have to administer 30 ml per kg crystalloid within 3 hours. Then it will be followed by vasopressor like adrenaline, noradrenaline, inotropes like dopamine, with the aim to maintain mean arterial pressure more than 65 millimeter of mercury. Amniotic fluid embolism, rare but deadly. It occurs due to entry of amniotic fluid into maternal circulation, which triggers a sudden anaphylactoid reaction. It has got a presentation of classical triad, that is hypoxia, hypotension, and coagulopathy. But coagulopathy is actually its late sequelae. We have to assess the patient. If a patient during labor or within 30 minutes of birth suddenly develops dyspnea, tachycardia, tachypnea, hypotension, and seizures, it is the amniotic fluid embolism. Have to go for supportive management, especially within the ICU. And we can use definitely Fesprogen plasma for coagulopathy, and in refractory cases, factor 7. Now, the non-obstetric causes, and the commonest one is cardiac disease. Like any other situation, it is associated with sudden events. 20% of the mothers die before reaching hospital or within the ambulance. But it shows the warning sign where we have to work, like chest pain, interscapular pain, wide pulse pressure, new onset murmur, and cardiac events actually occurs in pre-existing heart disease like ischemic heart disease, arrhythmia, and pregnancy-specific peripartum cardiomyopathy. pulmonary embolism is a leading cause of pregnancy-related death, 10 to 15% pregnancy-related death. But this data is from the Western world. We are fortunate enough that this incidence is much less in our country, but we have to be very cautious about the risk factors like previous thrombosis, obesity, inflammatory disease, and have to keep in mind that its highest risk is in the puerperium. It starts actually as a deep vein thrombosis, then travels to lungs and blocks the pulmonary vasculature. And the treatment is heparin, IV unfractionated heparin with loading dose of 80 units per kg to be given immediately, followed by continuous infusion of 18 units per kg per hour with the aim to keep APTT 1.5 to 2.5 times of the control value. Now, substance misuse we have always to consider, especially in the outside the hospital setup. Maximum toxicity can occur, though we don't see it on and often, but risk is when we treat it in severe preeclampsia with renal impairment. And we all know the antidote, that is 10 ml, 10% calcium gluconate IV. Local anesthetic toxicity can also occur due to high systemic absorption, and it is associated with early signs like dizziness, sedation, circumaural tingling, followed by convulsion, arrhythmia, and cardiac arrest. It has got very useful antidote, which I didn't see any patient to use it, but it is really a strong antidote, that is intralipid 20%, 1.5 ml per kg bolus, then 15 ml per kg per hour infusion. Following spinal or epidural complication, if the mother goes into collapse, it is probably high or total spinal block that we have to think. Now, the anaphylaxis, which is a life-threatening hypersensitivity reaction and sometimes life-threatening for the obstetrician as well, because it occurs very suddenly with rapid progression. Yeah, and common triggers are drugs. So we have to use drugs like ceftriaxone or penicillin-centered drugs after skin test. It can occur to many other conditions, but as it is sudden, we cannot actually predict it earlier, but we have to take precaution. It occurs due to massive vasodilation and fluid shift to the third space. There is bronchospasm. There is risk of myocardial ischemia. We can go for mast cell tryptase level to confirm the diagnosis, but whenever we suspect it, then we have to give adrenaline. 1:1000 adrenaline, 500 microgram IM, not IV. Now, management. If we act at collapse, we can stop death. For that reason, we need early recognition, timely referral, team approach, that is emergency obstetric team. Every tertiary level hospital at least should have an emergency obstetric team or response team. And we know the ABCDE response. Early recognition is possible by understanding the risk factors that I have already mentioned, that obstetric causes, pre-existing medical conditions, preeclampsia, sepsis. In addition, advanced maternal age, obesity, severe mental health issues, and low socioeconomic status are also considered as risk factors. Regarding early recognition tools, there is no single validated system exists, but we can utilize the available tools like shock index, which can be calculated just within twinkle of an eye, that is heart rate divided by systolic blood pressure. In emergency, it is to determine the amount of blood loss, normal 0.7 to 0.9, and more than 1 indicate massive blood loss. We can follow the rule of 30, which is used to measure severity of shock. If systolic blood pressure fall by 30 millimeter mercury, respiratory rate more than 30, hemoglobin or hematocrit drop by 30%, urine output less than 30 ml per hour, it indicates at least loss of 30% of the blood volume. 1 minute. This is modified early warning scores, that is MEO system, which is often used in Western countries in acute situation. I cannot go into the details due to time constraints, but we can use it in our emergency room. If the score is at or more than 7, it indicates acute deterioration. But this tool is very important, I must say, that is obstetrically modified OMQ SOFA for sepsis. It is also based on a scoring system 012 and based on based on organ dysfunction, like respiration is addressed by partial pressure of oxygen, coagulation by platelets, liver by bilirubin, cardiovascular system by mean arterial pressure, CNS by level of consciousness, kidney system by creatinine. And a cutoff 5 has high sensitivity 100% and specificity 95% in predicting septic shock. Now the immediate management ABCD approach have to start the basic life support as early as possible. It is actually a must know skill for all obstetrician and involve the multidisciplinary team. But before that, we have to know the physiological and anatomical changes in pregnancy that can affect resuscitation. Number one is autocaval compression. Just left lateral tilt of 15 to 30 degree will cause return of cardiac, making cardiac output to be increased by 30 to 40%. Another one is uterine blood flow is about 10% of the circulating volume after 20 weeks of pregnancy. So there is predisposition to hemorrhage and hypovolemia. We have to deal with aggressive fluid and empty uterus as early as possible. It will cause increased oxygen consumption. In addition, there is dilutional anemia that can reduce oxygen carrying capacity. That occurs due to residual functional residue volume from increased ventilation of the mother and diaphragm splinting. In addition, there is increased oxygen demand of the uteroplacental unit and fetus. So pregnant women has got prone to develop rapid development of hypoxia. We need to give early high flow oxygen, 100%, 10 to 15 liter per minute. Another thing that we have to keep in mind that breast enlargement, laryngeal edema, and reduced esophageal tone may make intubation difficult, makes the mother at high risk of aspiration. So we have to secure the airway very early. Now, first, when we find a patient of collapse, we have to check for response by shaking and shouting. We can follow the cow's instruction, which we actually do, like, can you hear me? Open your eyes, such type of thing. If there is no response, we have to call for help. We can call for an ambulance if we are in the community, and in the meantime, we have to keep open the airway. To open the airway, we have checked for obstruction and see in the picture just simple maneuver, head tilt, chin lift, or we can follow the jaw thrust maneuver. After that, we have to check the breathing for up to 10 seconds by looking, listening, or feeling the movement of the air from the nose and mouth of the casualty. If breathing normally, we have to place her in the recovery position and monitor their breathing. If no breathing, have to start CPR immediately. And for CPR, we have to place the casualty on a firm surface with a wedge under right hip to make the tilt 15 to 30 degree. Then kneel beside her and place the heel of one hand on lower half of sternum. Place other hand on top with a straightened arm. Then give 30 hard and fast chest compression up to down 4 to 6 centimeter. Then allow the chest to rise fully. And after 30 compression, have to give 2 rescue breathings. And have to ensure effective breathing by giving 100% oxygen. However, if oxygen saturation is at or less than 90, we have to escalate the support. Even intubation may be needed. We have to maintain the circulation to maintain adequate oxygenation, and for that reason, volume replacement with 2 large bore IV access. You have to keep in mind that it should be large bore so that large amount of fluid can be given, and CV line can also be considered, and have to control bleeding. In the meantime, we have to check the vitals. And now the D, that is disability or level of consciousness, have to assess by AVPU or GCS score. We have to check pupil for response. And the last but not the least, environment, that is exposure. We have to expose the casualty fully to check for any injuries or bleeding by maintaining the temperature, of course. And in every step, our effort should be to correct the reversible causes that I have mentioned, that 4HS and 4TS. So how long CPR? CPR can be continued without interruption until the patient shows sign of life. There is professional medical help that they who then take over, and defibrillator is attached. In such circumstances, some recommends to continue it at least for 20 minutes. Now, there is a 4-minute rule. That is, if return of spontaneous circulation is not achieved within 4 minutes of cardiac arrest, we have to perform an immediate perimortem cesarean section to increase the cardiac output in the circulation. But in every step, we have to save ourselves as well. When the patient is critical and dead, we have to inform our senior and administrator, have to ensure accurate documentation and brief patient party time to time, have to review the case through clinical governance process later on. So when and how to declare death? If there is no signs of life, like absence of carotid pulse, absence of heart sound and breathing, and absence of pupillary response to light, even after all these, we have to observe for a period of 5 minutes. It is always best that declaration should come from the anesthesiologist or emergency team. And my recommendation is to introduce AI in the management of the maternal collapse, because it can predict collapse early by analyzing the risk factor. It can detect that patient is going to collapse. Even it can support us and guide us for the diagnosis and the actions to that have to be taken. So in maternal collapse, when minutes matter, AI can turn data into timely decision. So, dear audience, let's end with the story that I have started. Probably I don't need to give the answer. Hopefully, we by the time know the answer and can manage this patient confidently. So, my key messages are: maternal collapse is sudden, cardiorespiratory CNS failure up to 6 weeks postpartum, requires immediate action. We have to go for structured approach, that is ABCD and 4H and 4TS. Most common cause is hemorrhage, most fatal one, amniotic fluid embolism and pulmonary embolism. We have to know the pregnancy-specific challenges that I have mentioned, and we should not delay. Resuscitation first, diagnosis later. Mother first, fetus second. And management, we know, is cause-specific with simultaneous resuscitation. So early recognition, rapid resuscitation, and multidisciplinary care are the key determinants of maternal survival. These are the references that I have taken, and thank you, with the hope that no women should die while bringing life into the world. Thank you all.
Thank you. Thank you so much, madam. Your presentation is really very excellent and very informative. Thank you so much, madam.
Thank you.
So now I request our honorable chairperson of this session, Professor Firoza Begum, madam. Madam, please make some comment about this presentation.
আমি শুনতে
জি
পাই
ম্যাডাম।
নাই, তুমি আমাকে রিকোয়েস্ট করছো। আচ্ছা, এখানে ডক্টর তাজবিরুল আছেন, ওনাকেও একটু বলতে বলো। আচ্ছা, যাই হোক, প্রথমে যেটা বলছি, দিস ইজ এ ভেরি গুড গ্যাদারিং. মোর দ্যান 300 people have joined, some on the Zoom and some in the Facebook. So this is a very good initiative. Actually, in every month since I took the charge of as OGSB president, in every month we used to go outside Dhaka to have a scientific seminar there. And this is the first month. That is, after 8 months, we have started this webinar. I don't know why. This we are too much busy probably in this month, so we could not make it outside. That's why we are arranging this webinar. So Tabassum has given a very good and details presentation. I don't think I need to add anything else, but this is a very elaborate presentation. And from this elaborate presentation, I can summarize some few points that when a mother comes in collapsed condition, this is a medical emergency. We must always remember this is an emergency. So it is not the one person that can make sure the health and whether the mother will survive or not. This is not the one person's duty. And from OGSB, we are actually holding this type of resuscitation procedure, that is life-saving skills. We are on nurses and midwives. And probably after this presentation, our doctors will be much more careful because every life matters. And we are dealing with not only on one life, we deal with 2 lives. So as Tabassum has mentioned, the maternal collapse, there is inadequate tissue perfusion and oxygenation that can lead to tissue perfusion, as there is less tissue perfusion, less oxygenation, there is lactic acidosis, and ultimately this acidosis sometimes can lead to multiple organ failure and patient death. And most common cause of this collapse is actually hypovolemic shock, that is maternal PPAs. This is one of the PPAs or APS. This is one of the most important cause in our country. Next comes the septic shock and other causes, as Tabassum has mentioned, cardiogenic shock. It can be a neurogenic shock. It can be an anaphylactic shock. So whenever we are dealing such a, and so you must be knowledgeable about the condition, why this has happened, and then we can manage according to the cause. That is patient resuscitation and treat according to the cause. This must, I must say, and we can take comments from Dr. Islam. Thank you all.
Thank you, madam. So, thank you, madam. So, I request Dr. Tazbur. Yes, madam, I can hear. Thank you, madam.
Proceed, Nusur. Tasbih sir is here.
So, Dr. Tazburul Islam, we request you please make some comment to our today's context, maternal collapse, about discuss our keynote speaker, Professor Tabassum Parveen. Make some comment, please. Dr. Tazburul Islam.
Thank you so much for having me today. And it was a wonderful presentation from Professor Tabassum Sultana. So actually, I learned a lot from her presentation as well. So, it is a life-threatening condition. It is rare, but life-threatening. So one thing I want to emphasize is a multidisciplinary approach. I don't think so one doctor can fix everything. So that is a collaborative work is needed to take care of those patients. Like we need, because it is acute cardiovascular collapse or neurological failure. So you need to involve the intensivist, cardiologist, pulmonologist, maybe a neurologist as well. So, that, and the other things I actually found out in her presentation that 20% cannot make to the hospital. So that means we need to have a robust EMS service, emergency medical service, that is non-existent in Bangladesh. I can share my story. I have a cardiac arrest 7 years ago when I was playing soccer. I was taken to the hospital in less than 10 minutes. and I got the CPR shocked, get the angiogram in 30 minutes. So, and now I'm here after 7 years. So how quick they took, the ambulance came in 1 minute to the field I was playing soccer. And from the field to the hospital, less than 10 minutes. So EMS service has to be improved unless we cannot give the good unless we cannot see the good outcome. In Bangladesh, there's another thing happen. Sometimes the hospital doesn't take the patient. They said we are full, or it is critical beyond our expertise. Take her to another hospital. Take her to another hospital. Patient is moving around in a huge traffic. Eventually, patient dies. So 20% what she mentioned probably higher in Bangladesh perspective. So I think OGSB can take a lead that no hospital can refuse the patient to do the initial resuscitation, stabilize the patient, and take the initiative on their own. Meaning that, don't tell the family, make their own, transportation arrangement. They will take the ownership and transport to the other hospital, which has a bed or has the expertise. So I think it was fascinating. I know more cases will come and we'll discuss about the cases as well. So thank you so much for having me. Thank you.
Thank you, Dr. Tazbrul. Now, Madam, with your permission, we want to go for panel discussion.
But no, sure. Before you start the discussion,
Ji, Madam.
no.
Yes, ma'am.
Sure. Can you hear me?
Yes, madam. Yes, madam, I
Okay,
can hear.
Before you start the case discussion, I want to make some comments because there are many people who can hear me here. Otherwise, they will not hear my voice. আমি ডক্টর তাজবরুল ইসলামের মানে অ্যাটেনশনটা চাচ্ছি যে হোয়াট উই আর প্ল্যানিং দ্যাট ইন বাংলাদেশ our district hospitals are not functioning properly. There may be post of 3 gynae consultants. There is present only 1 consultant. It is not possible for 1 person give 24-hour service. And in some district hospitals, there is no one. Some hospitals, there is 1 gynecologist, but no anesthetist. In most of the hospitals, there are no physicians, no anesthetist to take care of these patients. So patients come from the home in a very critical stage, brought to the hospital, that is district hospital or a medical college. From the district hospital, they want to shift don't want to take the load of this patient. So they shift the patient to some private clinic or a medical college hospital, and most of at least 1/3 of the patients die on the way. And আমি যেটা চিন্তা করছি, আমি আমাদের ডাক্তারদের উদ্দেশ্যে বলছি যে ইমিডিয়েটলি এই মাসেই নেক্সট মান্থে before 15th we'll have a meeting, because আমি সমস্ত আমার ডেভেলপমেন্ট পার্টনার্সকে রিকোয়েস্ট করছি যে আমাদের দেশের যে ডিস্ট্রিক্ট হসপিটালের যে অবস্থা, our health ministry should know this, and without functional district hospitals, this maternal death in our country will not be reduced. So we'll try to take some actions, and we need our cooperation from all our gynecologists, from all our colleagues in this respect. Thank you.
Yes, sir.
Thank you, madam.
I'm done.
Okay, now, with kind permission from madam, we are go for panel discussion. For moderation of panel, I humbly request our Dr. Fahmida Rashid Appa, Assistant Professor, Chittagong Medical College, Bangladesh, Consultant and Country Representative as per Bangladesh, Joint Secretary FSSB, Organizing Secretary OGSB Chittagong Branch, International Relationship Affairs Secretary, Editorial Board Member, Journal BCPS, and she has lots of national and international publication. I request Dr. Fahmida Rashid for moderation the panel session.
Thank you, Nusur. Assalamu alaikum. Today, as we gather to discuss maternal collapse in obstetric care, we are not just discussing a clinical emergency. We are confronting a reality that unfolds every day across Bangladesh. Let me start with a scenario. In a remote village, a mother begins to bleed after delivery. The family hesitates. Should we go now? Will it cost too much? Later, transport is arranged, though late. The nearest facility cannot manage the complication. She is referred again to a tertiary care center. By the time she reached a tertiary center, we are no longer trying to save her. We are trying to understand what went wrong. That is not a rare story. In Bangladesh, the maternal mortality ratio is still around 136 per 1 lakh live birth. Nearly half of the maternal death occurs around delivery or within first 48 hours postpartum, the very window where timely intervention can save lives. These numbers are just not statistics. They reflect delays, gaps, and missed opportunities. And in the critical window of maternal collapse, minutes matter, not hours. Today, we are privileged to have with us 4 exceptional panelists who bring not only expertise, but also lived experience from our own healthcare system. And also, we are honored to have Dr. Taslim Sir, who is from very well-facilitated establishment. Through this discussion, we aim to explore how to recognize maternal collapse early, how to respond effectively in low-resource setting, and most importantly, how to prevent these tragedies. Because every maternal death in such situation is not just a loss, it is often a failure of timing, system, and coordination. So let's begin with the panel discussion. So the screen is visible, I hope, right?
Yes, yes.
Visible.
Okay. So first question is to our panelist, Professor Sheikh Zinatar Nasrin Madam. So here, a 38 years old
You have
Bevida Para 2, previous 2 CS at 36 weeks present with fever, jaundice, and ascites. There is no fetal movement. Feature of coagulopathy seems prothrombin time more than 25 to 30 seconds. FPTT more than 60 seconds. FDP more than 40 microgram per ml. Fibrinogen less than 100 milligram per TL. And platelet 80,000. After admission, she developed hepatic encephalopathy. Supportive care and noradrenaline were given, even though the patient was deteriorating. So my question is to you, what are the red flags indicating imminent maternal collapse in this patient? Madam.
Well, thank you, Dr. Fahmida, for this very important question. Just before answering, I'd like to address Honorable Chairperson, Honorable Guest, Dr. Tasbir Islam, Firoza Madam, and all the beloved participants and the discussant in this webinar. Assalamu alaikum and very good evening. Well, your question is very, very logical because if we can recognize red flags, we can get ready and we can prevent the deterioration of the maternal collapse. Just we have heard the wonderful description.
সিনারিওটা রাখো সিনারিওটা রাখো কোশ্চেনটা না থাকলেও
Right.
সিনারিওটা রাখো সামনে
Ji, ji. So just we have heard the beautiful definition of maternal collapse from Dr. Tabassum Parveen. That is, maternal collapse is acute life-threatening event where there's a deterioration of the cardiopulmonary and respiratory system as well as neurological impairment, which needs immediate multidisciplinary intervention to optimize the outcome, otherwise she'll die. So for that, we have to know what are the red flag signs. What are the signs for imminent maternal collapse? That is why Fahmida has asked this question. So let us see our scenario. We can see the red flag signs here. The first of all, the very sensitive one is the encephalopathy. As soon as patient admitted, she is having encephalopathy. That means probably she is having confusion, because of this encephalopathy, she is disoriented or coma. So this is indicating that this lady may go into collapse at any time because encephalopathy is a very serious warning sign. Then Also in this situation, we can see that there is a patient also have shock. Probably the lady is having tachycardia, tachypnea, low blood pressure, shock index probably very, high. So that is another important warning sign that this lady at any time will go to the maternal collapse. And third one is very, very important. We can have scenario here that is severe coagulopathy. Here the FDP is 40, very high. Fibrinogen is very low, less than 1 gram per DL. And that indicates that she is having DIC. So that is one important red flag sign for the maternal collapse. And also, this lady, she is having fever, probably progressive jaundice, ascites, and no fetal movement, that is intrauterine fetal death. That is also another important sign for the maternal collapse. So this scenario is having lot of red flag signs that this lady or this woman may go into collapse very soon. So this is
Very fine, ma'am. You mentioned very well that what are the red flags. Now, suppose these patients had this red flag. So we must think of about acute viral hepatitis, acute fatty liver pregnancy, or HELLP syndrome. This patient might be suffering from these three. So how to differentiate between these three?
well in between the viral hepatitis, acute fatty liver, and HELLP syndrome, right?
Yes, ma'am.
So this scenario actually here we can see. Can you give the scenario, please?
Sure, ma'am.
Yeah. We can see here that this goes in favor of acute fatty liver. Actually, this acute fatty liver HELLP syndrome, they usually appears in the third trimester, and she's in third trimester. And viral hepatitis can appear at any time of the pregnancy. So the main complaints of acute fatty liver, usually there's a triad: severe nausea, vomiting, abdominal pain, and jaundice. And for HELLP syndrome, we can have the patient may complain of, severe, of course, nausea, vomiting, but probably most commonly she's complaining of right hypochondriac pain. Along with this, she might complain of severe headache, severe blurring of vision, and generalized edema. On the other hand, for the viral hepatitis, the patient would not have the serious complications. It is insidious onset, maybe history of exposure, she develops jaundice, and constitutional symptom is more. No headache, blurring of vision, or, unlike severe vomiting, if it is, fulminating case. And also the complaint for acute fatty liver, along with these symptoms, patient may complain of polydipsia, polyuria. And if we measure the blood pressure, probably the blood pressure is most of the cases of acute fetal liver is normal.
Ma'am,
Yeah.
you mentioned that, yeah.
But in case
so
of,
if you want to go for investigation for this patient.
yeah, right. So,
Yes, ma'am.
right. So blood pressure is,
Yes, ma'am.
one of the important. And if you go for the blood biochemistry and ultrasonogram, blood biochemistry gives a very good differentiating point between the acute fatty liver, HELLP syndrome, and viral hepatitis. Viral hepatitis is very straightforward. There will be all viral markers will be positive, but it is not be positive in acute fatty liver or HELLP syndrome. So if you go for that, the acute fatty liver, the blood chemistry, there will be profound hypoglycemia. That is the important sign or biochemistry, which is not present in HELP or others.
So you are telling about the investigation. For that, what first investigation you want to do for this patient?
Well,
what are the first investigation if the scenario or patient comes to you?
It is very obvious we are going for the complete blood count, where HELP syndrome, where it is a HELP syndrome, the hemoglobin is very low and LDH will be very high, which will indicate that there is a hemolysis, and platelets will be low in case of HELP syndrome. And
we have this investigation, prothrombin, FTP, FTP, and platelet.
Right.
What other first investigation you want to differentiate between these three?
Yeah, well, we can go for, that blood sugar. I already mentioned that will be very profound low in case of acute fatty liver, but it could be normal in case of HELP or, viral hepatitis. Then we can go for the ammonia. It will be very, very high in case of acute fatty liver. And
you are telling about the acute fatty liver. Do you want to go for the liver enzyme for first,
Yes,
or
you
the
can
other
go for the
investigations?
transaminase. Transaminase that will be very high in case of viral hepatitis, ALT, AST will be very high. I mean 500 or 1000. On the other hand, this transaminase will be moderately elevated in case of HELP. On the other hand, acute fatty liver, there will be higher transaminase. So these will be higher in these cases. And also if we go for, yes?
Yes,
And
ma'am.
also if you do the ultrasonogram, probably in case of acute fatty liver, there is a
So
bright liver.
this patient will not give us enough time to do ultrasound.
Yeah,
Probably
yeah.
if there is a bedside
There's an,
ultrasound, that is okay.
bedside. Yeah,
Yeah.
right, definitely.
So,
And
ma'am, keeping you on that spot, I want to go to Tasbih, sir. Sir, if the patient comes to, in our scenario, what we do, that's different thing. But if this patient come to your situation, what is when we will refer the patient to the ICU? Immediately or after managing the patient while in the labor room? Tasbih, sir.
Yeah, thank you so much. It's a fascinating case and well described by Professor Jonathan Strain. So this patient who has significant coagulopathy, and she's only 38 years old and 30 weeks of pregnant. Actually, we take that, and she's in hepatic encephalopathy and shock. By definition, immediately should be in ICU. There is no role of playing in the floor or in the ward before transferring to ICU. Probably will be too late. Somebody already in shock and encephalopathic and significant coagulopathy look like more acute fatty liver of the pregnancy, as Dr. Professor Gina Nasin says, more hepatic involvement, suggesting is more fatty liver rather than HELP. But the treatment is the same, basically is immediate delivery. And
So,
actually,
should we deliver the patient first, or should we refer the patient
now you have to
or resuscitate
resuscitate
patient to
first.
ICU?
You have to resuscitate and also deliver. That's why I'm saying that it's a collaborative approach or multidisciplinary approach from the intensivist, ICU, and also OBGYN, because need a immediate delivery. She's 36 weeks and also need a resuscitative measures. So I think it's very important to involve. As you know, when you deliver the patient will back to normal within few days. So as long as we do the resuscitation, but that particular patient, when you ask me which should to go when the patient come to the emergency room, should go straight to the ICU, not even HDU, straight to the ICU for better management. Thank you.
So it's
The
in
other
your
things I want to
scenario.
mention one thing. I want to mention one thing quick about the management of shock. It's very simple. If you follow the algorithm, like, when the patient come in, don't look at the Professor Tabassum Sultana mentioned about the shock index. So easy. Systolic pressure heart rate divided by systolic blood pressure. So when you see that when heart rate divided by systolic blood pressure, but better to use MAP, the mean arterial pressure, and the heart rate, not the systolic blood pressure, because it counts it also taking the consideration of the diastolic blood pressure. That's a MAP is better than the systolic. Exactly. Second is look at the patient is warm or cold. Then look at the patient is fluid overload, not fluid overload, like JVP, crackles, and edema. Then do the focus. That I'm saying the important thing is the focus. If you put the probe on the heart, and if you see the left ventricle is not moving, it is cardiogenic shock. If you see the right ventricle is not moving, it's a PE. If you see the big pericardial effusion, is tamponade. If you see the left ventricle is very hyperdynamic, it's a septic shock or hypervolumic shock. Then if you see a lot of B lines, that means patient is in pulmonary edema. If you see a lot of free fluid in the belly, that means patient is hemorrhage, probably bleeding inside the belly. So it's very important to learn how to do the POCUS, the point of care ultrasound. I think OGSB can take a lead and PH can be a part of it to train the junior doctors how to do the POCUS. It takes 5 minutes to find out what causing the shock. Thank you.
Okay, sir. Thank you. So I'm going to right now to Professor Firoza Begum madam. So that's the scenario answer Sir has given, that in the Western world what they do. But in our scenario, in district hospital, in tertiary care hospital, the obstetric ICU is not adjacent to the obstetric ward, and there is the facility is very scarce. In that state, if the patient come to our setting, what we should do? Yes, ma'am.
Shate, I want to make a comment.
Yes, ma'am. Yes, ma'am.
Shate, can you hear me?
Yes, madam. Yes, madam.
Acha,
Completely.
I want to make a comment that this before we are not looking after our patients properly. This
Mhm.
scenario shows that we are not taking care of our patients appropriately
Yes,
because she has come at 36 weeks with fever, jaundice, and ascites. This has not developed in one day. It has taken several days. So it is our negligence that we could not recognize the condition earlier, and that's why she has developed hepatic encephalopathy, ultimately shock, and probably the patient is dead. So this is our responsibility to diagnose the condition earlier before her condition deteriorates that we cannot save her life.
Okay.
Assalamualaikum, madam. Can I ask a question?
No, we'll just give you floor after later, ma'am. Just we need to finish this up. After that, we will take the question from the audience. So I'm moving again to our Sheikh Zina Nasrin, madam. So how to manage this patient? If the patient comes, already management is a bit
Described, already
yeah,
described.
described.
I mean,
So
immediately, Dr. Tazril also said, and Tabassum very nicely mentioned, immediately this patient need to be ICU.
immediately to ICU. So could early diagnosis and timely referral and escalation of the care have changed the outcome? Could have changed the outcome?
Definitely. Firoza madam just now said that this lady was not properly managed. If we could have
Yeah.
early diagnosed, probably this wouldn't happen to her. So
Exactly.
proper diagnosis, proper care is very important to prevent the progression of the disease.
Excellent. So thank you, madam. Thank you for all of your expert opinion. Now we are moving to the next scenario. It's for Professor Shahnara Chaudhary, madam. At 26 years old, debuted 3 para 2, previous 2 CS, 36 weeks twin pregnancy. Presented with severe respiratory distress, labor pain for 11 hours. On admission, she was found that SpO2 is 88, pulse 120 beats per minute, 120 per minute, and pulmonary crepitation found in both lung field. She was diagnosed as a preeclampsia with severe feature and acute LVF. She underwent emergency LACS under general anesthesia and immediately shifted to ICU postoperatively. But there she deteriorates and develops hypotension. And ultimately, what we know, everyone know, cardiorespiratory collapse. So, what early indicators of maternal collapse are present before surgery in this patient? If we could have looked properly. Professor Shahnara Chaudhary, ma'am.
Thank you so much, respected President, our guest, and all the speakers, and all the panelists, and all the dear participants observing and hearing. Good afternoon. It's a very important question, and this is the real scenario we face every day in the tertiary level hospitals, especially in government setting. Here, definitely there is some red flags or so-called pre-warning signs. You can see that there is a severe hypoxia as evidenced by partial oxygen saturation is 80%. That is features of respiratory failure. And also there is tachypnea, respiratory distress,
additional device is
and-
there. Just stop করে দেন।
and tachycardia 120, and there is definite sign of crepitations and signs of pulmonary edema and left ventricular failure because she is a case of severe preeclampsia with severe features, and also twin, and also she is in a prolonged labor for 11 hours. Yeah.
Yes, ma'am. So these are the early indicators that you mentioned. So we should look for before surgery. So should immediately LSCS versus stabilization have been prioritized in this scenario, ma'am?
This is my observation, and this is the main tragedy, and we should address these issues very carefully. What we have learned that what is the common dictum is that if there is severe preeclampsia with severe features, the main target is to deliver the fetus as quickly as possible. But following this dictum, we always neglect the resuscitation and stabilization procedure. So here, according to my opinion, there should be patient should be stabilized first, especially in the ICU setup, especially with multidisciplinary team. And first we have to reassess, then we should act properly. We should recognize, after recognizing, we should act properly in the ICU setup. You can see that here she had cesarean section, and it is probably under general anesthesia, which reduces the venous return and cardiac compromise, exaggerate the cardiac compromise. At the same time, if we rush for cesarean section in supine position for prolonged time for cesarean section, we know that it is worsen the pulmonary edema. At the same time, intubation for general anesthesia, it again causes further hemodynamic instability. And
so about the stabilization, madam, a bit about the stabilization. So what is the first line respiratory support that needs to stabilize this patient, for this patient?
Professor Tabassum beautifully described that it is the A, B, C, D steps. Stepwise sequential act is the main thing. Number one is that for airway clearance, propped up position, high flow oxygen, and non-invasive like respiratory support like CPAP or BiPAP, whatever it is available. And if needed, sometimes intubation can be done for respiratory
She is a
improvement.
case of LVF, ma'am. So what is the optimal management of acute LVF in pregnancy?
For establishment of the circulation, after establishing the respiration, we should go for strict fluid restriction, then IV diuretics, high dose furosemide. Then we have to consider nitroglycerin infusion to reduce the preload because there is a pulmonary edema. And at the same time, if there is, you can see that there is hypotension. So support from inotropes is very important. At the same time, simultaneously, we have, if needed, because this patient may quickly, because she had severe features of preeclampsia, quickly she can ended up with seizure. So we should look at that by giving Maxalf if her respiration and urine output improves.
Thank you, madam. About the LVF management, sometimes we worry about to give furosemide. আমরা furosemide দিতে ভয় পাই. She is pregnant right now. So what will happen to the baby? And I said something like this. So should we give? What is the dose or what is the recommendation? Should we worry about giving furosemide to this patient, or we can liberally give as much she needs to manage the LVF?
Actually, here always there is two issues. One is mother and one is fetus. But here in this condition, the maternal survival is the first priority because the mother is in very critical position. So furosemide should be given liberally. Sometimes 14 to 8 ampoules can be given.
Thank you, madam. Thank you for your input. So now I'm moving to Tasbih sir. Tasbih sir, for this patient, what you do in your setup?
Can you go back to the findings?
Yeah.
So if you look at the patient presentation, patient actually diagnosed with severe preeclampsia with severe features and acute left ventricular failure with saturation is 88%. So that patient is, as you know, that Professor Shahanara Begum says that maternal health is a priority. So patients, if the blood pressure is okay, then you give Lasix and you can start nitroglycerin if it is hypertensive emergency, meaning blood pressure is very high, by definition more than 180. But if the patient is hypotensive, then you cannot give Lasix, you cannot give nitroglycerin, then probably you have to start with the noradrenaline or with norepinephrine. The first choice. But for respiratory, that is the the hemodynamic support. But if you look at the respiratory support, typically two group of patients really do well with a non-invasive ventilation. One is acute left ventricular failure. Second is acute exacerbation of COPD. These two patients actually should try BiPAP immediately. And you can see you can avoid intubation. But be prepared, back of the mind, okay, I'm going to put the patient on BiPAP, but if the patient doesn't do well, then prepare for the intubation. Don't delay. Don't play with the number for hours before you decide to intubate. It's maybe too late. Normally, if you put the patient on BiPAP, the same concept, it decreases the preload by increasing the intrathoracic pressure so that it can improve the pulmonary venous congestion. But if the patient doesn't improve within an hour, that means when they put the patient on BiPAP, you should see immediate improvement in respiratory distress, less tachycardic, less tachypneic, saturation is getting better, patient look much comfortable. Then you do the blood gas 30 to 45 minutes later to see the improvement and do the fine adjustment. But if I see patient still in distress, despite on BiPAP, and he played with the number, he increasing the IPAP, EPAP, FiO2, and still patient in distress, not getting better, probably that patient need to be intubated immediately. Thank you.
You are telling about the BiPAP, which is very scarce in our setup. So, Firoza Madam, where there is not, we don't have any BiPAP. What to do in this situation to improve the oxygen saturation? Firoza Madam? Firoza Madam, are you there? Madam?
Madam কে দেখতে পাচ্ছি না কিন্তু।
Madam দেখতে পাচ্ছেন না?
Actually, Professor, Dr. Swamida, we have BiPAP nowadays available.
Not in all hospital, ma'am.
Madam,
Okay.
ম্যাডাম আসছেন।
Firoza
No,
Madam.
I could not use my laptop, so I have joined from my iPhone.
মোবাইল,
Madam, just asking you that.
No, I
BiPAP,
could hear.
okay,
Yeah,
BiPAP is not available in all the district hospital or Upazila health complex or many of the D category hospital, government hospital. In that scenario, what we should do to rise the oxygen saturation or to give oxygen? What are the alternatives of BiPAP in our scenario?
এই পেশেন্টের যে সিনারিও যেটা তুমি
জি,
দেখো, she has previous to cesarean section 36 weeks and severe hypertension 160/110, and তার এই পেশেন্টটাকেও আমি কিন্তু সেই একই কথা বলবো, this condition should be recognized earlier and referral to a particular situation or particular place where there is management is possible. এখন যেটা করা হয়েছে যে তোমার সব জায়গায় সব ফেসিলিটিস নাই, ইভেন ইন দ্য বেস্ট মানে সেন্টার উই হ্যাভ নট দিস টাইপ অফ ফেসিলিটিস, সো আওয়ার রেফারাল সিস্টেম শুড বি ইমপ্রুভড, and once this patient come to a center, say in your medical college, you will call, she has developed left ventricular failure. Do you listen to the heart? Do you listen to the chest? We
Already
don't.
we had there is a bilateral capitation in the both lungs.
No, but most of us, আমি তোমার কথা বলছি না, most of us do not put a stethoscope on the heart, on the chest. Then we just rush for the cesarean section. But first we have to stabilize the patient. You should call your cardiac emergencies. You should call your anesthetist, that is obstetric anesthetist. And then we decide what we to do. We can give, in this case, we have to lower the blood pressure. We have to improve her cardiac condition by giving some, we can give Lasix because she has developed left ventricular failure. So we can give Lasix. And then after that, after stabilization of the patient, you could do the cesarean section. This is my advice. I don't know what others
তাজবির স্যারকে
will
একটু
say.
জিজ্ঞেস করছিলাম, সবাই ইনপুট দিয়েছে ম্যাডাম অলরেডি, আপনি হয়তো ছিলেন না। তাজবির স্যার, আমাদের কি বাইপেপ ছাড়া কোনো অল্টারনেটিভ আছে যেটা আমরা বাংলাদেশে ইউজ করতে পারি? কোভিড এর সময় আমরা দেখেছিলাম। Tasbih, so can you just mention what are the other alternatives that could be used instead of a BiPAP?
If you look at the way we treat the respiratory failure, you start with the oxygen first, right? So when you see certain oxygen just gives the oxygen, but it does not decrease the respiratory distress. So, and you give, if the patient is hypertensive, like this patient, then you give Lasix, you can start on nitroglycerin drip, or at least you can give nitroglycerin spray. We don't like spray, to be honest. This is very unpredictable, but in a low resource setting, you can try. But eventually, you have to bring down the blood pressure. We like labetalol or the nitroglycerin, not the hydrolazine. Hydrolazine actually is very unpredictable, is not actually advocated to use for hypertensive emergency. And the Lasix you have to give. But for the respiratory support, trust me, the nasal cannula or mask you can give, absolutely, that is the starting point. But I think it's time now to find out that how to give the BiPAP. And also, I'm pretty sure that, if we take a initiative, okay, nasal cannula, non-rebreather, high flow, BiPAP, then intubation. So that is the algorithm we have to follow. So I cannot substitute BiPAP for nasal cannula. But that is, patient will be in distress and it's dying in front of you. So probably we need to work on now two things. One is Professor Firoja Begum saying again and again, I'm so impressed that early recognition and awareness from the patient party, they come early, sometimes they come very late. And number two is early recognition by us, by the physician. So this too is so important to prevent the complication. So, and also I'm giving emphasis of establishing robust emergency medical service. Because if they may even look at that, who runs the ambulance, those who doesn't have any idea about the no medical knowledge. So if they can start the treatment at home and bring the patient to the emergency room, it will be more stable than if someone who doesn't have any idea how to manage the patient. Like me, I'll tell you just 30 seconds. When I had a chest pain, my son called the 911 from the field. We were playing soccer. Emergency patient came, emergency medical personnel, they put me in an ambulance. I'm asking for fentanyl. I was asking for morphine because I was so much in pain. The ambulance person says, no, I cannot give it to you because your blood pressure is 80s now. If I give it to you, you will die. I'll just give us 10 minutes. I'll take you to the hospital. That despite I was telling him, being a physician, and he knows I'm a physician, that give me fentanyl. He said, no, I cannot give it to you because if I give it, your blood pressure will crash and you will die. So see how knowledgeable the emergency medicine personnel, and saved my life. I was so thankful to him. He didn't give it to me. So it's very important to establish this work. It's a government, public, private collaboration we need it now. Otherwise, I don't think we can improve the service. Thank you.
Definitely, sir. If we all work together, definitely we can establish that that means facilities in our hospitals as well. So now I am moving to our next scenario. This is for Professor Fahmida Islam. Ma'am, a 35 years old multipara delivered at home and presented after 3 hours with massive vaginal bleeding, shock. Her BP was not recordable and pulse was absent. On per-abdominal examination, uterus is flabby. Despite resuscitation and uterotonics, she develops recurrent per-vaginal bleeding and went into shock. So my question is to you, what are the key steps in managing maternal collapse due to PPH? Madam.
Assalamu alaikum. Thank you, Dr. Fahmida Rashid, for your very practical question. It is a very common scenario in our medical college and also in the other tertiary center, from where lots of patients are referred from other centers as well as from the home setting.
Professor.
My name is also Fahmida. I'm Fahmida Islam Chaudhuri. Can I continue? Can you hear me?
শোনা যাচ্ছে, তুমি কন্টিনিউ করো ফাহমিদা।
ওকে, থ্যাংক ইউ ম্যাডাম। আমি আসলে আমার প্রশ্নের উত্তরটা একটু বাংলায় দিতে চাই। এর মধ্যে লটস অফ ডিসকাশন হয়েছে, যেখানে তাজবির স্যার খুবই স্ট্যান্ডার্ড সেট আপে যা যা করা যায় বলেছেন, আমরা আমাদের সেট আপে যা করতে পারি সেগুলো বলা হয়েছে। বাট ম্যাটার্নাল কলাপস মানে অবস্টেট্রিক শকের পেশেন্ট যে কোনো কারণেই হতে পারে, তাদের কিছুটা ডিফারেন্স হতে পারে ম্যানেজমেন্টে, বাট দ্য বেসিক ইজ অলমোস্ট সেম। যেমন ওয়েল প্রিপেয়ার্ডনেস ইজ নিডেড ইন দিস টাইপ অফ ক্রিটিক্যালি ইল পেশেন্ট। এই পেশেন্ট গুলো আসলে লেভেল 2 অথবা আমাকে যে সিনারিওটা দেওয়া হয়েছে দ্যাট ইজ এ লেভেল 3 ক্রিটিক্যাল পেশেন্ট। এই পেশেন্টটা তাহলে কোথায় ম্যানেজমেন্ট হবে? এখানে রিসাসিটেশন অ্যান্ড ম্যানেজমেন্ট উইল গো সাইড বাই সাইড। সো প্লেস কোথায় আমরা এই পেশেন্টটাকে আমাদের হসপিটালে রাখি? আমরা যেহেতু আইসিইউ পেশেন্ট গুলো সরাসরি অবস্টেট্রিক ওয়ার্ডে আসে, আমরা অবস্টেট্রিক ওটিটা 24/7 খোলা থাকে। এই পেশেন্ট গুলোকে আমরা সরাসরি অবস্টেট্রিক ওটিতে নিয়ে যাই, যেখানে তার ইনকিউবেশন ফ্যাসিলিটি রয়েছে অথবা মনিটর গুলো খুব ভালো কাজ করে, অ্যানেস্থেটিস অ্যাভেলেবেল। সেই জায়গায় আমরা এই অবস্টেট্রিক কলাপসের পেশেন্ট গুলো নিয়ে আমরা ফার্স্ট রিসাসিটেশনে যাই। একটা টিম, রিসাসিটেশনের টিমটাতে থাকেন আইসিইউ স্পেশালিস্ট, তাদের সাথে আমরা আগেই হোয়াটসঅ্যাপ গ্রুপে একটা কমিউনিকেশন করি, এবং আইডিয়ালি অবস্টেট্রিক র্যাপিড রেসপন্স টিম যেটা পিপিএইচ বান্ডেলে আমরা করে রেখেছি, সেই টিমটার পাশাপাশি ইন্টারডিসিপ্লিনারি টিম, তার মধ্যে অ্যানেস্থেশিয়া অ্যান্ড ক্রিটিক্যাল কেয়ার মেডিসিন, দুইজন এক্সপার্টই কিন্তু আমাদের প্রয়োজন। সাথে রয়েছে ব্লাড ট্রান্সফিউশন। ব্লাড ট্রান্সফিউশন ইজ ভেরি ক্রুশিয়াল। আমাদের এখানে ট্রান্সফিউশন মেডিসিন খুবই কোঅপারেটিভ, বাট there are many lackings in transfusion regarding transfusion facilities. Also calculating the number of transfusion, how we are doing is blindly we are doing, but it should not be. আমাদের যেটা থম্বো ইলাস্টোগ্রাফিক গাইডেড ব্লাড ট্রান্সফিউশন এবং কম্পোনেন্ট ট্রান্সফিউশন, সেটা আমরা ল্যাকিং, but transfusion specialists are giving us the pack cell, fresh frozen plasma আর platelet 1:1:1 করে পাওয়া যায়। বাট দিস নিডস এ ওয়েল প্রিপেয়ার্ডনেস। এটা আগে থেকেই আমাদেরকে একটা সেট প্রোটোকল হতে পারে, সেটা খুবই ছোট একটা হসপিটাল, মেবি এ প্রাইভেট ক্লিনিক, বাট দেয়ার শুড বি সেট প্রোটোকল যেটা ঝুলানো থাকবে। এবং এইরকম পেশেন্ট হলে অবশ্যই যে লেবার রুম গুলো ওয়েল ইকুইপ থাকতে হবে, শুধু পিপিএইচ বক্স থাকলেই চলবে না, সাথে ক্রিটিক্যাল কেয়ার লাইফ সেভিং যে টুল গুলো রয়েছে, ইভেন এন্ডোট্যাকিয়াল টিউবে অনেক সময় ব্যাটারি থাকে না, অনেক সময় ইনটিউবেশন করার মানে পজিশন থাকে না লেবার রুম গুলোতে, বাট দিজ আর ভেরি ইম্পর্টেন্ট। এই জিনিসগুলো আমরা ওটিতে পাই, সেজন্য আমরা এই পেশেন্ট গুলোকে আমরা আমাদের অবস্টেট্রিক ওটিতে ম্যানেজ করি। তারপরে যেটা রয়েছে সেটা হচ্ছে যে আমরা ট্রান্সফার যেটা হয়ে আসে পেশেন্ট, এখানে আসলে একটা ওয়েল কমিউনিকেশনের খুব অভাব থাকে। গ্রামের যে উপজেলা থেকে আসে সেখান থেকে কখনোই আমরা রেফারেল পাই না। আমাদের একটা খুব ইম্পর্টেন্ট টুল আছে, যে টুলটা হচ্ছে am I audible, Dr. Shati?
Yes, yes, you're audible very much.
আমাদের
Yes,
একটা
madam. Yes.
অ্যান্টি শক গার্মেন্টস আমরা যেটা ওজেএসবি খুব ভালোভাবে সাপ্লাই করেছে, ইভেন উপজেলাতেও দেওয়া হয়েছে। আনফরচুনেটলি এই অ্যান্টি শক গার্মেন্টসটা শকের পেশেন্টকে কেউই সহজে ব্যবহার করার কথা মাথায় আনেন না, যেটা মানে রিলাক্টেন্ট, আমি জানি না কেন, বাট দিস ইজ এ ভেরি ক্রুশিয়াল এবং ইম্পর্টেন্ট একটা টুল যেটা আমরা ইউজ করে সহজেই পেশেন্টকে রিভার্সেবল স্টেজতে নিয়ে আসতে পারি। এবং ইমার্জেন্সি প্রিপেয়ারনেস এর জন্য আমরা কিছুক্ষণ আগে তাজবিরুল স্যার বলেছেন যে কলাপস পেশেন্টে, যে কোনো কলাপস পেশেন্টকে ফোকাস করতে হবে, পয়েন্ট অফ কেয়ার আল্ট্রাসোনোগ্রাম। এটা নিয়ে রিসেন্টলি ক্রিটিক্যাল কেয়ার মেডিসিনে আমাদের ওয়ার্কশপ হয়েছিল, আমাদের অনেক ট্রেনি অংশ নিয়েছে এবং আরো এটা কন্টিনিউয়াস হচ্ছে চিটং মেডিকেল কলেজে গ্যাপ দিয়ে।
ম্যাডাম
সরি,
না না ঠিক আছে ম্যাডাম, আপনি যে স্টেপ গুলো বলছিলেন আমরা এরপরে যদি যাই, হোয়াট আর দ্য টাইমিং অফ সার্জিক্যাল ইন্টারভেনশন অ্যাপ্রোপ্রিয়েট ফর দিস পেশেন্ট?
এখানে আমি একটা জিনিস বলতে চাচ্ছি যে ফোকাসটা করা খুবই জরুরি, কেননা ফ্লুইড ম্যানেজমেন্ট, হাইপোভলিমিক শক বা কার্ডিওজেনিক শক, সবখানেই ফ্লুইড ম্যানেজমেন্ট উইল ডিপেন্ড অন দা ইনফেরিয়ার ভেনা কাভা, তারপরে লাং এর বি লাইন, তারপরে পেরিকার্ডিয়াল ইফিউশন আছে কিনা, দিস আর ভেরি ইম্পর্টেন্ট। 5 মিনিটও লাগে না এত কুইক ওনারা করে। এবং এখানে আমাদের দরকার, আমাদের ওটিতে একটা আল্ট্রাসোনোগ্রাম যেটার জন্য ফোকাস করা যায় এরকম একটা ইকুইপমেন্ট দরকার, 2 নম্বর ডিফিব্রিলেটর, 3 নম্বর থ্রম্বো ইলাস্টোগ্রাফ, যেটা দিয়ে আমরা কুইক ব্লাড কোয়াগুলেশনটা অ্যাসেস করতে পারবো। এবং থ্রম্বো ইলাস্টোগ্রাফ গাইডেড ট্রান্সফিউশনটা যদি আমরা ইনশিওর করতে পারি, এটাতে মর্টালিটি অনেক অনেক কমে আসবে। আমরা এরপরের প্রশ্নে রিসাসিটেশনে আমরা কি প্রিন্সিপাল গুলো অ্যাপ্লাই করে আমাদের মেডিকেল কলেজে আমরা দেখেছি পেশেন্টের আউটকাম আমরা অনেকটাই ইমপ্রুভ করতে পেরেছি। নেক্সট কাম যে ল্যাপারোটমি, প্রশ্নটা ছিল ল্যাপারোটমি, তাই না?
দাদাদের পরের কোয়েশ্চেনটা দেন। হ্যাঁ ম্যাডাম, হ্যাঁ থ্রম্বো ইলাস্টোগ্রাম কি ম্যাডাম চিটং মেডিকেল কলেজে আপনাদের
না, আমাদের এখনো আসেনি, বাট আমরা রিকোয়ারমেন্ট দিয়েছি। এবং আমাদের হেমাটোলজির কলিগ যারা বলছেন তারা বলছে যে আমরা হোল ব্লাড ট্রান্সফিউজ করে আসলে পেশেন্টদেরকে আরো ট্রালির দিকে ঠেলে দিচ্ছি। এবং এটা মনে রাখতে হবে, হাইপোভলিমিয়া যখনই হচ্ছে দেয়ার ইজ চেঞ্জ ইন হাইপার কোয়াগুলেবিলিটি। এবং ফ্লুইড রিসাসিটেশনে আমরা অনর্বল অনেক বেশি ফ্লুইড দিয়ে ফেলি অনেক সময়, যার ফলে কোয়াগুলেশন ডাইলিউশনাল কোয়াগুলোপ্যাথি হয়। So this is very key point. Thromboelastograph machine can be available, আর এটা করা যেতে পারে। এটা খুব বেশি চিটং এর একটা
ফাহমিদা, একটু রিকোয়েস্ট আসছে ইংলিশে বলতে, খুব মিস করছে, বলছে আমরা মিসিং ভেরি ইম্পর্টেন্ট ইনফরমেশন। ইয়েতে চ্যাটে আসছে, একটু বলো।
Okay, যেটা হচ্ছে কি স্টেপস I meant resuscitation and management will go side by side. Place should be a place where resuscitation is easier and quickly can be done. And in that place, the POCUS should be done first. POCUS is the first point, ultrasonographic assessment of whole body, especially the lung, heart, and inferior vena cava to calculate the fluid. Then the thromboelastography guided blood requirement or the massive transfusion protocol in our setting. We can set it earlier. What will we do after assessment of blood loss? Then team, the obstetric rapid response team is already there, but we need seek help from the interdisciplinary team, especially anesthesia and critical care medicine, and also the transfusion expert. And we should have set protocol. It can be very simple and we can follow that, and so that we can quickly communicate. And we have made also a WhatsApp communication group so that the scenario can be very quickly communicated with the others. And on the spot of emergency, the seniors should be involved from the very beginning. This is our lackings. The senior consultant will not come only for the hysterectomy. That person should be available on the spot when the patient is in our floor.
Madam, in this scenario, the patient was had in surgical intervention. Was the time appropriate for this patient?
You know, this is a case of refractory PPH. There is already bleeding, bleeding in spite of all the uterotonic, all the primary first bundle care. So we need to do aortocaval compression as well as uterine balloon tamponade. And in the meantime, we are resuscitating the patient. UBT is an intermediate step between the surgery and the medical management. So if the UBT fails, then we must be very prompt in deciding the laparotomy with high risk bond. You must remember in your mind that this is a place where you have to take the risk bond, you have to fill up the debrief tool, which is well organized in a PPH bundle approach. And when there is risk of any death, collapse patient usually very frequently can be fatal, and then you are in a medical legal issue. So you must take care of those points also.
So in this patient, we give you a lot of uterine drug. Along with that, there are other drugs that we should keep ready in our setup.
Drug card.
What are the
drugs?
Second drug.
I cannot hear you properly. Can you repeat the question?
Uterotonic that should be ready.
She's asking, Fahmida,
Drugs.
what are other
About the
drugs need to be
Apart from
ready?
uterotonic, what are the other drugs that
uterotonic.
should be kept ready in our setup?
Yes,
apart from the uterotonic drug, what are the other drugs?
Tranexamic acid, they are asking.
Yes, tranexamic acid is in the protocol, already we gave in the first care bundle, and also the anesthesia drug and are available.
Vasopressor.
And adrenaline is
Yeah.
started after fluid resuscitation. It is a part of resuscitation, and all the life-saving drugs for for the cardiopulmonary resuscitation. Here, I would like to some drugs, especially when the patients are in shock. The intubation is different from the patients of routine patients, and also the patient is in a critical in a 15 to 30 degree tilt in left lateral position, and defibrillator is needed definitely, and we need to equip. Madam was asking for our respected president was asking what we are going to do in our Jela hospital and also in medical colleges. We want this machine in our setup.
So, madam, about the tranexamic acid, what is the time that you can get to give the tranexamic acid? Within how many hours the tranexamic acid could be given?
Yes,
After PPH?
within half an hour.
Within half an hour. Okay, half
And
an
it
hour.
can be repeated. It can
It
be
can be repeated.
repeated within next. If it is not controlled, you can repeat again within 3
ম্যাডাম আমাদের
hours.
অনেক
Again.
সময় বলে যে ট্রানএক্সামিক অ্যাসিড এবং ব্লাড সাইড বাই সাইড দেওয়া যাবে না, এই ধরনের কথা আমরা বলি। হোয়াট ইজ দ্য অ্যাকচুয়াল মানে ম্যাটার পারপাস?
দেয়া যাবে না, ঠিক না, বাট উইদিন হাফ এন আওয়ার ইজ রেকমেন্ডেড। আর পেশেন্ট ট্রানএক্সামিক অ্যাসিড অনেকে রুটিনলি লিখে দেয় যে 8 আওয়ারলি, এইটা দেয়া যাবে না, এটা পেশেন্ট টু পেশেন্ট ডিপেন্ড
No
করবে।
prophylactic role.
Yes.
Madam,
And
about
also
the
fluid also, you do not you should not prescribe 8 liter 4 liter fluid, 5 liter fluid, not like this. You have to assess the patient slowly, gradually. At least you can give hourly order like ICU patients. And monitor the outputs and important vitals in a continuous monitor with a continuous monitor. Monitors are available now.
So you are telling about the protocol of massive transfusion protocol. What is the
Yes.
protocol in such scenario? Can you repeat, ma'am?
Massive transfusion protocol is for this type of collapse patient. But I mentioned in my early talk that it must be thromboelastographic guided transfusion.
If it is not available, ma'am, then
Available, then we go. OJSB has a protocol. We follow with the hematology 1:1:1. 1 unit of PRBC, 1 unit of fresh frozen plasma, and 1 unit platelet. Fresh frozen plasma is preserved in blood bank, but in our setting, people are doing that, just separating the PRBC and plasma. This plasma is not ready to transfuse. We must make the thaw of the fresh frozen plasma, then we will transfuse it. So time is needed.
Okay, ma'am. From you, I am moving into Tasbih sir. What is the massive transfusion protocol in your scenario, in your establishment?
We just used that massive transfusion protocol last week in a PPH patient. So she was the 33 years old patient, had massive bleed after the delivery. So there's two terms called massive transfusion protocol, but better term is massive hemorrhagic protocol.
Okay.
The massive hemorrhagic protocol actually involves not only the transfusion, which is 1:1, this as correctly mentioned, but hemorrhagic protocol involves other measures as well, like hysterectomy. Here we do more IR embolization, intervention, radiology, guided embolization, and avoid surgical intervention. Number 3 is tranexamic acid we give. So those are the measures we do. That's why we use the term more massive hemorrhagic protocol than massive transfusion protocol. Number 2 is you need a big bore IV cannula, like 16 or 18 gauge. Here, sometimes that is the fastest we can give. Then still you have time and patient is not responding. Then I put a cordis, 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 which is
What does
8
it mean,
French. 8 French. So you can cordis, CORDI. That is the IV line called cordis. That is 8 French. And that you can give much faster blood transfusion. The important thing is we have a device.
What about
We
CV
can
line?
give.
What about
We
CV
have
line?
so
CV line. CV line.
yes,
Central venous
central
line.
line actually. So it can give. It takes time to put the central line. The cordis. If you put a central line, put a cordis one. Cordis is like a central line. It's a big board, 8 French. So if you look at the central line, is 13 French. So 7 to 13 French. So the another one is for massive transfusion protocol. There's a device, the machine, which can give faster flow. So our nurses actually put the device on and start transfusion through the 16 or 18 gauge. By the time we can put the central line or cordis, but don't waste your time putting a central line. 16 or 18 gauge peripheral line is as good as central line.
Okay.
And give tranexamic acid. I know BMU has interventional radiology. I know the private hospital has interventional radiology. Involve them so they can do the embolizations earlier rather than going for the surgical intervention.
Okay.
Thank you.
Okay, ma'am. Now moving into Professor Famida Islam, ma'am. Could earlier use of definitive measure, that means hysterectomy, could have saved the patient, ma'am? Famida, ma'am?
Yes. Regarding hysterectomy, I think no. Resuscitation was the key point, timely resuscitation. Then laparotomy. Then we have so many alternatives to hysterectomy here. And Tasbih sir also here mentioned that uterine artery embolization. All these can help this type of young patient.
Okay. So, Professor Firuza, madam, what's about your thought about the massive transfusion protocol we are following in our setup in Bangladesh? Every center is using a different protocol here. So, do we want to standardize the protocol from the OGs we have given? Do you want to implement it widely in all the setting of Bangladesh?
No, before I answer your question, the answer is 35% of our patients still deliver at home. That is the saddest thing. And this is the fault of our obstetricians because we could not convince our patient that please come to the hospital, your life will be saved. We could not convince the patients because we do not give any time to the patients. That is my first message. And second message is your question, that is the protocol. Actually, the patient has lost much more blood before she comes to the hospital because she was brought in a state of shock. So you have to, that is how much blood you have to, patient has lost. We could use the shock index. We could use that is the rule of 30. That is how much to assess how much blood she has lost. And the protocol actually we follow is different people follows different protocol because the Famida already said that we cannot immediately do the test that whether the patient needs RCC or whether she needs any blood products. So we give 2:1:1. Somebody gives 4:1:1. These are different, but 1:1:1. This is not followed. I think. I think this is not followed nowadays. We actually follow 2:1:1 or
From FIGO, madam.
4:1:1.
What you're telling 2:1, that is from FIGO.
Yeah. That
Can I
we
add
follow.
one thing quick? Can I add one thing?
Sure,
And that is, Dr. Tasbirul Islam, there is no invasive, that is no artery embolization procedure is available anywhere in
No,
Bangladesh.
madam, it's probably available in some private setup. One
In
of
the
our
private
patients,
center,
yeah,
but these
not in
patients do
government.
not go
Yeah.
to the private center.
No, yes,
This
ma'am.
is not available even in BSMMU.
Yeah.
So we cannot do anything. As Pamida has said, we could go do the anti-shock garments for these patients. And we have trained our obstetricians on anti-shock garments, but nobody is using it. We just de-shoulder the patients from one center to another, from one center to another. And we are de-shouldering the patients. If we could timely help this patient, this patient would be saved.
Okay.
And another thing is what I forgot. If last week, one patient from Borishal Medical College, she came in a state of severe ascites. She had pulmonary edema. Her bilirubin was 7 and she was hypertensive. She was brought to Borishal Medical College and her creatinine was high. Her liver enzymes were all high. And this patient, actually, they consulted me. And they did not wanted to do the surgery in Borishal Medical College. But I took the chance, that is, I pressed them, please do it here. Otherwise, the patient will die on the way. And they did the surgery there. The patient's life was saved. The hepatologist did not agree. They said the patient will go into hepatorenal shutdown. She will die. But finally, the patient was saved and she is still in Dhaka Medical. Next day, she was referred to Dhaka Medical College and now she is fine. So this is the things that we should take care. We should take sometimes we should take some drastic actions. Otherwise,
That's right.
save the life of the patients.
Exactly. A timely decision, precise decision could save a life, just like yours, madam. Tasbih sir, want to add something probably? Are you telling?
Yes, about the massive transfusion protocol, that 1-to-1-to-1, that is PRBC, FFP, and platelets, actually, you can use whole blood. So if you use the whole blood, it is perfectly 1-to-1-1. So in hemorrhagic shock, I know Bangladesh whole blood is more available than the PRBC or FFP or the platelets.
Sir,
Just use the whole blood.
we are currently opting out from the
So
whole
if you
blood.
use the whole blood, if you
No,
use
we
the
are
whole
not
blood, you
using
don't
it.
do.
We are just
Excuse-
opting out from the whole blood. We are just going into the component right now. Bangladesh.
No. I'll
No,
tell
no,
you.
no.
The recommendation now
Yeah.
for the acute trauma or acute hemorrhagic shock, give whole blood rather than going for 1-to-1-1, because whole blood is the natural 1-to-1-to-1 ratio. So now if you look at the Western world, in our patient, when we have acute trauma patient, acutely bleeding or hemorrhagic shock, we actually give more whole blood rather than go for 3 product separately.
Okay.
So to use whole blood, somebody's in hemorrhagic shock. That I'm going to test.
So that's the new thing. That's the new thing. We are.
Famida, you need
we're using
fresh
more
blood.
and more whole blood now.
Okay, so I got it, madam.
Famida, you need fresh blood.
Got it,
Whole
ma'am.
blood, but not a stored blood.
Okay, ma'am.
Actually, in our setting, madam, we are getting a PABC takes more time. That's why whole blood is, we should give whole blood to save their life.
Okay.
No,
Whole blood
I
is
am
recommended
mentioning
now.
that do
Whole blood
not
is
use the
recommended.
stored blood.
Fresh
Use
blood.
the fresh blood.
Fresh whole blood. That's it.
জি, madam.
So this
ঠিক
is the
কথা
message from if it's not available, component is not available, fresh whole blood is the alternatives. So we are moving into, thank you all for your input. Now we are moving into our fourth scenario. Scenario 4. Yeah. So to the Masuda Sultana, she's a fetal specialist. A 35-year-old woman with 16 weeks of pregnancy with history of 3 CS followed by expulsion of the fetus. After 2 days, she presented with severe abdominal distension and feature of sepsis. Laparotomy was done and found uterine rupture, and there is sanguineous fluid in the peritoneal cavity, fibrinous exudates, inflamed peritoneum, and distended loops. And there is early and flimsy adhesion between bowel loops. But despite surgery and ICU care, on the second postoperative day, she progressed to, as usual, septic shock and developed ARDS. Dr. Masuda, what are the early signs of sepsis leading to maternal collapse in pregnancy in this patient?
Assalamu alaikum. Am I audible?
Yeah.
Thank you, Dr. Fahmida, for a nice question. This patient is also very neglected patient, and there must be some factors that lead to abortion and rupture uterus. Even with that, patient came to medical service very late. sepsis after abortion can escalate very quickly. So recognizing early warning signs are very critical. A maternal collapse often the end result of untreated and rapidly progressing infection. There are so many warning signs: fever or hypothermia, feeling very unwell. In this patient, she had history of expulsion, and 2 days after she presented with very severe lower abdominal pain and features of sepsis. Their features of sepsis should be fever or hypotension, extreme fatigue, weakness, chills, shivering, sweating. There should be tachycardia, shortness of breath, hypotension, cold, clammy skin, mental state. There may be decreased mental alertness, confusion, disorientation, and there
So
should
now
be
I
some
am asking
pregnancy
about the
specific.
early sign. That means you mentioned clearly early sign of fever, tachycardia, tachypnea, and alternate state and abdominal pain. These are the early sign you mentioned very properly. So so could earlier surgical intervention or referral have prevented this deterioration of this patient? What's your thought?
If this patient came early to medical service and earlier intervention can be taken, including early intervention, including early resuscitative steps, and early surgical intervention could prevent this deterioration.
Okay. So how should septic shock in obstetrics be managed differently from general ICU patients? In general ICU, there is a management is different, but in obstetric shock, septic shock due to an obstetric patient or obstetric cause, it's different, something a bit different. What are the difference?
This patient should be managed in ICU with multidisciplinary team approach. Septic shock in obstetrics overlaps with a lot with the general ICU management care, but there are some important differences. Pregnancy causes a huge physiological changes in vital signs, vital parameters like increased heart rate, lower blood pressure, and leukocytosis may be there. So early recognition sometimes may be very difficult. So modified MUSE or other scoring system can be applied for early identification of serious condition. Removal of infective focus, such as retained product of conception, evacuation, or in severe cases, like in this case, may need hysterectomy as well. Antibiotics should cover gram-positive, gram-negative, and anaerobic as well. Should
What type
cover
of
all
antibiotic?
the microorganisms.
Broad spectrum antibiotic.
Broad spectrum antibiotic. In general ICU, there may be some septic focus in only one system, and that may need one categories of antibiotic.
Okay, but before going into management, Dr. Masuda, before going into the management, what is the key investigation you want to do for this patient? Key investigation.
In this patient, at first, complete blood count.
One investigation that you want to do before going into management.
Complete blood
Before
count.
going into management, before going antibiotic, we should send sample for high vaginal swab for culture sensitivity, and then we can start broad spectrum antibiotic.
So what's your perspective about the serum lactate in this patient? Doing serum lactate.
Serum lactate is very important in this case, as if serum lactate is more than 4, then it will indicate tissue hypoxia and lactic acidosis. Okay. The management of this serum lactate, if it is high, it will affect the management.
So you are telling about the management. Please proceed.
And as in general ICU, we can resuscitate with fluid. Here we can also resuscitate with fluid, but fluid management a little bit different in this case, as in pregnancy, there is reduced colloidal oncotic pressure and capillaries are very leaky. So if we over treatment with fluid, then every chance of development of pulmonary edema. So
what is the recommended dose of fluid for this sort of patient, in obstetric patient?
A patient is already now in shock. So patient is in septic shock. So 1 liter fluid should be given within about 15 minutes, and then another liter should be given in a little bit more time, and with adequate monitoring of the patient, preferably with central venous line.
Okay. And what about so what is the main definitive step for the patient? Management step?
For definitive management step in this patient, first we should give, along with resuscitation, broad spectrum antibiotic. And once the patient is stable, then we should go for laparotomy, followed by thorough peritoneal toileting and identification of the actual problem. And then in this case, as there is rupture uterus and serosanguinous fluid in the peritoneal cavity, uterus may not be repaired at this stage. So
If it is repairable, should we keep it or should we remove the uterus?
It will be a source of infection later on if we preserve it. And within 2 days, it should not be repairable. It is already infected very much. And if we try to repair, every bite will tear on its own.
Okay.
So hysterectomy is the definitive treatment.
Okay, thank you. Thank you very much. So now moving to Tasbir sir. Sir, what's your thought about this patient's management in your setup?
As rightly said, that a patient should be resuscitated. The choice of fluid is a balanced fluid, not normal saline. Normal saline can cause hyperchloremic acidosis. So balanced fluid means Ringer lactate or Hartmann solution. You can use it. That is the best fluid you can use. You use colloid or albumin when you give too much fluid, meaning the patient is getting 3, 4, 5 liters of fluid already, and you're really worried about the overload, then you can consider albumin. But in the colloid, the ratio is 1/3. That means 1 liter of crystalloid is equivalent to 300 cc of 400 cc of albumin. That means if you want to give less volume, but get the same hemodynamic response, then you can use albumin, but after using at least 3-4 liters of crystalloid. That's number one. How fast you give the fluid? You have to give the 30 ml per kilogram within 2 hours. You can give actually 1 liter, you can give as fast as 15 to 30 minutes. So try to give that 30 ml per kilo of the fluid in 2 hours. That's number two. Number three is, there's two things. One is antibiotics, broad spectrum, very broad spectrum. Then you can de-escalate. If you see, say you started gram-negative, gram-positive MRSA coverage, then day 3, it came out as, say, E. coli, then take off the vancomycin, MRSA coverage. So de-escalation is very important. But when you start the broad spectrum, because you're actually dealing with very sick patient. You don't want to take any chance. Number 4 is source control. That means if the infected fetus inside or the some, abscess collection, fluid collection, whatever the source, that need to be treated surgically. So it's very important. The source control is such as patient has empyema or patient has infected fluid proliferation, drain it. Ascites, drain it. So it's very important source control. So I think here there's another one patient develop ARDS. So that means patient will require significant respiratory support. In ARDS, typically you can try high flow, you can try BiPAP, but back of the mind, you always think that if BiPAP, there's a high risk, high chance of failure, and patient will require intubation. So pneumonia patient or ARDS patient, unfortunately, BiPAP is not the great, but you can try high flow, but many patients end up with intubation. Indication of steroid in septic shock is validated. That means you should use steroid in septic shock patients.
What sort of steroid and what's the dose for this patient.
Okay.
Okay.
So if you use, there's a two condition. If you use for the septic shock, by definition, when the patient is on pressure, like noradrenaline or vasopressin, you use hydrocortisone, 50 milligram, 6 hourly.
Okay.
But if you, for the ARDS, it's different dosing. We use mostly dexamethasone, that is 20 milligram daily for 5 days, followed by 10 milligram daily for another 5 days, total of 10 days of steroid dexamethasone for ARDS. For septic shock, how long the steroid will be? The 50 milligram hydrocortisone Q6 until patient come off the pressure. So when the patient come off the vasopressor, so non-adrenaline vasopressin is off, then we wait for 24 hours, then we discontinue the steroid. Thank you.
So crystalloid, 30 milligram per 30 ml per kg body weight, and steroid. These are the key points you mentioned here.
Antibiotics as well,
and
broad
definitely,
spectrum.
Definitely antibiotic, broad spectrum. So moving into Professor Firoza Begum, Madam. So what are the investigation that could be given to do for this patient before starting or after starting and antibiotic and management? Firoza, ma'am.
আমি এটা তো আনসার হয়ে গেছে অলরেডি ডক্টর ইয়ে হ্যাজ আনসার্ড that are investigations, that is complete blood count. Actually, কি বলে Farmida, this type of patient, when a patient comes with shock, can you imagine previous 3 seizure, she had ruptured uterus and she came with shock and with sepsis. Because of the sepsis, she has developed shock. So you have to assess the stage of the shock. How much that is, whether it is an early stage or whether it is in late stage. Accordingly, you should manage. But the things that Dr. Masuda has already mentioned, that you should do the complete blood count, you should do the high vaginal swab, you should assess the patient, especially the SOFA score we can do, and we should call our partners, that is our anesthetic ICU partners, ICU anesthetist, to give some advice regarding the management of the patient. And even start with broad spectrum antibiotic after taking the high vaginal swab, and then you can do the laparotomy and hysterectomy as she has mentioned. But what next? I don't know. Every patient, every scenario you have described, 4 scenarios, we have lost all and every patients.
Is there any role of doing CRP and procalcitonin in this patient? Or it's obvious?
In this type of patient, CRP will be high.
So obviously the patient is in infective state.
So CRP will be high. I don't think CRP will much help in this case.
Okay. So we do have some question here in the chat box. Should we take it or should we move on? Because it is already...
It is already 2 hours already has passed.
Okay. That's it. So thank you all the panelists and and our chairperson for your input. There was a wonderful panel discussion. I want to do a virtual clap for all of you, ma'am. Thank you very much. So as we come to the close of this powerful discussion, I find myself reflecting not just as a moderator, but as a clinician working within this very system. Today, we revised a hard truth. Most maternal death in Bangladesh is preventable, definitely. We discussed hemorrhage, eclampsia, and sepsis, and conditions we are trained to manage. Yet, what often determines the outcome is not knowledge alone, but how early we act, how well we coordinate, how strong our system in under pressure. When a mother collapses in a rural setting, she carries with her not just a medical condition, but the weight of delay. And yet, there is hope. Bangladesh has made remarkable progress, reducing maternal mortality significantly over the decades. But now, we are at a stage where further reduction will depend on strengthening the emergency response, as Tajbisa said, improving referral system. Definitely, OGS will take the steps in the referral system and ensuring skilled care at every birth. Let us remember, behind every statistics is a mother, a child, and a family. If we can reduce even one delay, if we can act even a few minutes earlier, we can change the ending of the story I said earlier. I extend my deepest gratitude to our respected chairperson, keynote speakers, and all the panelists for their invaluable insight.
And Dr. Tasbirul Islam.
Definitely.
You have forgot to give
No,
him
no,
thanks.
definitely. And let us carry this discussion beyond today into our wards, our labor room, and our decision making. So now I am handing over the mic to our reporter, Dr. Nusur Akhtar, for concluding the session. Thank you very much for having me.
Thank you. Thank you all the respected panelists for your
নিশু
nice
আমি কি
discussion.
ফিরোজা ম্যাডামকে একটা কোশ্চেন করতে পারি একটু কি 2 সেকেন্ড দিবে
কে জিজ্ঞেস
ম্যাডাম
করতে চাচ্ছে?
ম্যাডাম শারমিন
আসসালামু
সিদ্দিকা,
আলাইকুম
জি ম্যাডাম, আপু অনেকক্ষণ ওয়েট করছেন।
জি ম্যাডাম আসসালামু আলাইকুম আমি অ্যাসিস্ট্যান্ট প্রফেসর ডক্টর শারমিনা সিদ্দিক ঢাকা মেডিকেল কলেজ থেকে
হ্যাঁ বলো, কিন্তু টাইম কিন্তু এখন
জি
হ্যাঁ বলো
2
একদম 1 সেকেন্ডে।
2 সেকেন্ড হচ্ছে যে ম্যাডাম আমাদের পিপিএইচ ম্যানেজমেন্টে কোয়ালিটি অফ সার্জারি এন্ড কোয়ালিটি অফ ম্যানেজমেন্ট এটা একদম আপ টু ডেট প্রোটোকল অনুযায়ী করা হয় কিন্তু ফ্যাক্ট যেটা যে ব্লাড পাওয়া যায় না টাইমলি ব্লাড ট্রান্সফিউশন ডিপার্টমেন্টে ব্লাড থাকে না এবং মিসম্যাচ ব্লাড ট্রান্সফিউশন এত পরিমাণ হচ্ছে ম্যাডাম ভালো ওটি করার পরেও দেখা যাচ্ছে অনেক রোগী মারা যাচ্ছে ইভেন গ্রাফট ভার্সেস হোস্টও হচ্ছে তো ম্যাডাম আপনার নলেজ একটু দিচ্ছি কাইন্ডলি যদি আমাদের ট্রান্সফিউশন মেডিসিন বিভাগে সাথে একটু কথা বলি এই ব্যাপারটা যদি একটু এনশিওর করে দিতেন টাইমলি ব্লাড পাওয়া যায় না ম্যাডাম খুবই কষ্ট হয় তখন দেখা যায় যে বিভিন্ন সেন্টারে যায় এবং এমন মিসম্যাচ ব্লাড ট্রান্সফিউশন হয় যে ভালো রোগী প্রাইমারি রোগীও পিপিএইচ এ মারা যাচ্ছে এটা একটু আপনি যদি কাইন্ডলি আমাদের ট্রান্সফিউশন মেডিসিন বিভাগের সাথে একটু কথা বলে কালেকশন অফ ব্লাডটা একটু তাদের বাড়ানো যায় নেগেটিভ ব্লাড স্পেশালি
You are working in Dhaka Medical College Hospital. If this is the scenario in Dhaka Medical College Hospital, can you imagine the scenario in whole Bangladesh?
Whole Bangladesh.
This is a very bad thing that our scenario has not improved. Even though Famida has mentioned that our maternal mortality has reduced, we are far away from achieving the SDG goal. We are far away from achieving the SDG goal. If we want to achieve the SDG goal, we should practice with knowledge. This is my message. We should practice with message. We should take care of our patients as our own relatives. Then we can save the lives of the patients.
Thank you.
Continue, Koro.
So thank you, our respected panel of experts. Thank you all. We learned a lot of things. We need multidisciplinary team approach. We need rapid action for such type of patient management by multidisciplinary team. We know that acute hemorrhagic shock, we give fresh whole blood. And we learn some terminology. There is massive transfusion protocol or massive hemorrhagic protocol. So thank you, panel of experts. Now I request our chairperson, Professor Firoza Begum, madam. Madam, please give us some your valuable opinion regarding chair session.
I have talked much, so nothing I have to say, but I must thank all the persons, all our OBGYN specialists who have joined this program, especially thanks to Dr. Tasbirul Islam for his time and for his valuable input, and thanks to Professor Tabassum Parveen, and also all the panelists for their hard work. That is, they have given the information regarding all these case scenarios. But this is the saddest thing is that in this program, all the patients you have seen that they have expired. That is the saddest thing. So we should be very much careful in our daily practice. This is my comment. Thank you, everybody.
Thank you, madam.
Thank you, madam. Thank you all for patient sharing.
Thank you, Rajni sir. That was a wonderful insight from you. And thank you all the panelists, definitely.
All the panelists and Dr. Tasbirul stay with us. Another thing, Professor Tabassum madam said, our priority first mother, then fetus. And 62% is reversible case. But Firoza madam mentioned 35% delivery at home. So we try to bring all our pregnant mother to hospital delivery, into institute delivery. Thank you all. Thank you for patient sharing.
Thank you, madam. Madam ke sabse beshi dhanyabad because madam has selected the topic, very time demanding. So